Welcome, everyone. Today we're doing a clinical deep dive into a really serious topic, Periprosthetic Joint Infection, or PJI. We'll be walking through the epidemiology, the diagnostic challenges, and the treatment strategies for what is a major complication in orthopedic surgery.
So let's start with a number that really sets the stage. Between 1.5% and 2% of all primary hip or knee replacements end up with a PJI. Now that might sound like a small percentage, but think about the sheer volume of these surgeries every year. It adds up to a huge number of patients, and the fallout is just immense. We're talking severe morbidity and a massive drain on healthcare resources.
So to be clear, what are we talking about? A periprosthetic joint infection is an infection that involves the artificial joint itself and all the tissue surrounding it. And its significance really boils down to three things. It makes patients incredibly sick, it carries a real risk of mortality, and it is incredibly expensive for the entire healthcare system.
Here's our game plan for this explainer. We'll start by looking at the scale of the challenge. Then, we'll get into the tricky business of diagnosis and figuring out which bugs are to blame. After that, we'll cover treatment, talk about the complications that can arise, and wrap up with the most important part, prevention.
All right, let's jump right into our first section, the challenge of PJI. We're going to look at why this is such a persistent and, frankly, growing problem. Get this, infection is the single biggest reason a hip replacement fails and needs to be redone within that first year. That is a massive deal. And this problem isn't going away. In fact, it's set to get worse. As our population gets older and more people get joint replacements, we're expecting to see a lot more of these infections. It's a huge public health challenge on the horizon.
Okay, Section 2. Let's talk about diagnosis. One of the biggest hurdles in treating PJI is that the bacteria are incredibly sneaky. They form something called a biofilm on the surface of the prosthesis, which is like a shield that protects them from our immune system and from antibiotics.
So the crucial question for any clinician is this: how do you find bacteria that are literally hiding inside this microscopic fortress? The answer lies in a really meticulous and standardized approach to getting samples and identifying the pathogens.
It really comes down to a three-step protocol. First, during surgery, you need to get multiple tissue samples, usually 5 or 6. This helps make sure you find the real culprit and don't just grow a random contaminant. Second, and this is key, you sonicate the implant that's been removed. This basically uses sound waves to shake the bacteria loose from that protective biofilm so they can be grown in a lab. It dramatically increases your chances of finding them. And finally, you have to be patient. You culture these samples for up to 14 days, because some of these organisms grow incredibly slowly.
So once we've successfully flushed them out, who are these microbial culprits? Let's move on to Section 3 and meet the usual suspects. Knowing who they are is fundamental to treatment.
Take a look at this data. It is overwhelmingly a staph party. Coagulase-negative staph and Staphylococcus aureus together cause almost 90% of these infections. This is probably the single most important fact for guiding that initial empirical choice of antibiotics before you have the final culture results.
And it gets a little more nuanced, because the likely culprit can actually change depending on the clinical picture. For a standard, acute PJI, you're betting on staph. But in something like a spontaneous bone infection, you'll also see streptococci pop up. And in kids with osteomyelitis, you have to think about a completely different bug, Kingella kingi. It just highlights how important context is.
All right, Section 4. We've found the bug. Now, how do we get rid of it? Treating PJI isn't a one-person job. It requires a full-on, coordinated counterattack from a whole team of specialists, blending both surgery and medicine.
Getting the best outcome for the patient absolutely depends on this team. You need the orthopedic surgeon to physically clean out the infection, the infectious disease expert to quarterback the antibiotic plan, the microbiologist to ID the bug and its weaknesses, and the clinical pharmacist to make sure the drug doses are perfect. It's a true team sport.
So, to see how this all works in practice, let's walk through a classic scenario. A patient who shows up with a PJI not long after their initial surgery.
The go-to strategy here is often something called DARE. That stands for debridement, antibiotics, and implant retention. The surgeon goes in and aggressively cleans out all the infected tissue. At the same time, you start antibiotics immediately. A common choice is vancomycin plus ceftriaxone. Why that combo? Because it gives you really broad coverage against our usual suspects. The vancomycin hits all the gram-positives, like MRSA and other staph, while ceftriaxone takes care of strep and many gram-negatives. Of course, dosing has to be spot on, tailored to the patient to be both effective and safe.
You know, this whole process of choosing the right antibiotic before you have all the information can be pretty intense. And one of the sources I read had a perfect and pretty funny description for it. It said, the decision-making can feel like a microbiologist's dating life. It's complex, it often requires combination therapy, and sometimes you just have to hope for the best. I think that captures the feeling perfectly.
Now let's move into a more serious topic, and Section 5, complications. Because even with the most aggressive treatment, PJI carries a significant risk of severe problems that go way beyond just the infected joint.
The infection in the joint can act like a launch pad, spreading bacteria through the bloodstream to the rest of the body. This can lead to devastating consequences, like secondary infections in the bone or the spine, and even life-threatening systemic conditions like sepsis or an infection of the heart valves called endocarditis.
This chart really drives home how serious these complications are. The baseline mortality risk for PJI is already quite high, up to 5%. But if that PJI leads to a complication like endocarditis, the mortality risk just skyrockets. It's a stark reminder of why early diagnosis and getting control of the infection source is so incredibly critical.
And that brings us to our final and most important section, prevention. Because when you look at how devastating a PGI can be, it's crystal clear that the best offense is a good defense. The ultimate goal has to be preventing the infection from ever happening in the first place.
Effective prevention isn't about one single magic bullet. It's a whole bundle of strategies. It includes things like giving prophylactic antibiotics at the right time, fanatical hand hygiene from the entire team, dealing with any skin infections before surgery, and of course, maintaining sterile technique. Simple things like not bathing the wound can also make a big difference in preventing contamination.
So this leaves us with a final, big-picture question to think about. As technology and demographics lead to millions more people getting joint implants in the coming years, will the prevention strategies we have today be enough? Are we prepared to outsmart a microbial world that is constantly evolving? The answer to that is going to shape the future of orthopedics.